Welcome to this essential guide on understanding the use of methotrexate in treatment of ectopic pregnancy. As a woman or a healthcare professional, it's crucial to be informed about the use of methotrexate in treatment of ectopic pregnancy. Methotrexate is an antimetabolite chemotherapeutic agent that binds to the enzyme dihydrofolate reductase, which is involved in the synthesis of purine nucleotides. This interferes with deoxyribonucleic acid synthesis and disrupts cell multiplication. Methotrexate has long been known to be effective in the treatment of leukemias, lymphomas, and carcinomas of the head, neck, breast, ovary, and bladder. It has also been used as an immunosuppressive agent in the prevention of graft versus host disease and in the treatment of severe psoriasis and rheumatoid arthritis. The effectiveness of methotrexate on trophoblastic tissue has been well established and is derived from experience gained in using this agent in the treatment of hydatiform moles and choriocarcinomas. As used in the treatment of ectopic pregnancy, methotrexate is administered in a single or in multiple intramuscular injections. Treatment with methotrexate is an especially attractive option when the pregnancy is located on the cervix or ovary or in the interstitial or the cornual portion of the tube. Surgical treatment in these cases is often associated with increased risk of hemorrhage, often resulting in hysterectomy or oophorectomy. Successful medical treatment using methotrexate has been reported in the literature with good subsequent reproductive outcomes. By avoiding surgery, the risk of tubal injury is reduced. Indications: medical therapy for ectopic pregnancy involving methotrexate may be indicated in certain patients. To determine acceptable candidates for methotrexate therapy, first establish the diagnosis by one of the following criteria: abnormal doubling rate of the beta-human chorionic gonadotropin (BHCG) level and ultrasonographic identification of a gestational sac outside of the uterus. Abnormal doubling rate of the BHCG level, an empty uterus, and menstrual aspiration with no chorionic villi. A number of other factors must also be considered once the diagnosis is established, as follows. The patient must be hemodynamically stable, with no signs or symptoms of active bleeding or hemoperitoneum, must be met by every patient. The patient must be reliable, compliant, and able to return for follow-up care, must be met by every patient. The size of the gestation should not exceed 4 cm at its greatest dimension, or exceed 3.5 centimeters with cardiac activity on ultrasonographic measurement. Exceeding this size is a relative, but not absolute, contraindication to medical therapy. Absence of fetal cardiac activity on ultrasonographic findings. The presence of fetal cardiac activity is a relative contraindication. No evidence of tubal rupture. Evidence of tubal rupture is an absolute contraindication. Beta-HCG level less than 5,000 nmol. Higher levels are a relative contraindication. A study by Bonin et al. Examined the records of 400 women who received methotrexate for ectopic pregnancy and concluded that predictive factors for successful methotrexate treatment include an initial HCG value 1000 IU ELA and favorable early HCG kinetics, and that predictive factors of treatment failure include hematosalpinx and pretherapeutic blood progesterone 5 n-grams mmol at diagnosis. Contraindications: a beta-HCG level of greater than 5,000 IU lead, fetal cardiac activity, and free fluid in the cul-de-sac on ultrasonographic images, presumably representing tubal rupture, are contraindications to medical therapy with methotrexate. Other contraindications to the use of methotrexate include the following: documented hypersensitivity to methotrexate, breastfeeding, immunodeficiency, alcoholism, alcoholic liver disease, any other type of liver disease, blood dyscrasias, leukopenia, thrombocytopenia, anemia, active pulmonary disease, peptic ulcer disease, renal, hepatic, or hematologic dysfunction. Adverse effects and mandatory patient counseling. Adverse drug effects include the following: nausea, vomiting, stomatitis, diarrhea, gastric distress, dizziness. Treatment effects of methotrexate include an increase in abdominal pain, occurring in up to 2/3 of patients, an increase in beta-HCG levels during the first 1 to 3 days of treatment, and vaginal bleeding or spotting. Before injection of methotrexate, the patient must be counseled extensively on the risks, benefits, and adverse effects of the treatment, and on the possibility of failure of medical therapy, which would result in tubal rupture and necessitate surgery. Patients should be aware of the signs and symptoms associated with tubal rupture, and they should be advised to contact their physician with significantly worsening abdominal pain or tenderness, heavy vaginal bleeding, dizziness, tachycardia, palpitations, or syncope. Methotrexate treatment protocols. A number of accepted protocols with injected methotrexate exist for the treatment of ectopic pregnancy. Multiple dose regimen. Initial experience used multiple doses of methotrexate with leucovorin to minimize adverse effects. Leucovorin is folinic acid that is the end product of the reaction catalyzed by dihydrofolate reductase, the same enzyme inhibited by methotrexate. Normal dividing cells preferentially absorb leucovorin. Hence, it decreases the action of methotrexate, thereby decreasing methotrexate's adverse systemic effects. This regimen involves administration of methotrexate as 1 mg/kg/IM on days 0, 2, 4, and 6, followed by 4 doses of leucovorin as 0.1 mg/kg on days 1, 3, 5, and 7. Because of a higher incidence of adverse effects and the increased need for patient motivation and compliance, the multiple dosage regimen has fallen out of favor in the United States. Single-dose regimen. The more popular regimen today is the single-dose injection, which involves injection of methotrexate as 50 mg/ml/IM in a single injection or as a divided dose injected into each buttock. Studies comparing the multiple methotrexate dosage regimen with the single dosage regimen have demonstrated that the two methods have similar efficacy. Day 0, obtain beta HCG level, ultrasonography, and plus mass dilatation and curettage. Day 1, obtain levels of the following: HCG, liver function, blood urea nitrogen, creatinine. Evidence of hepatic or renal compromise is a contraindication to methotrexate therapy. Methotrexate 50 mg/kg is administered by IM injection. Advise patients not to take vitamins with folic acid until complete resolution of the ectopic pregnancy. They should also refrain from alcohol consumption and intercourse for the same period. Day 4. The patient returns for measurement of her beta HCG level. The level may be higher than the pre-treatment level. The Day 4 HCG level is the baseline level against which subsequent levels are measured. Day 7. Draw beta HCG and AST levels and perform a complete blood count. If the beta HCG level has dropped 15% or more since Day 4, obtain weekly beta HCG levels until they have reached the negative level for the lab. If the weekly levels plateau or increase, a second course of methotrexate may be administered. If the beta HCG level has not dropped at least 15% from the Day 4 level, administer a second IM dose of methotrexate, 50 mg/kg on Day 7, and observe the patient similarly. If no drop has occurred by Day 14, surgical therapy is indicated. If the patient develops increasing abdominal pain after methotrexate therapy, repeat a transvaginal ultrasonographic scan to evaluate for possible rupture. Treatment monitoring protocols. The best predictor of success of medical therapy is the initial beta HCG level. Success exceeded 90% for single-dose methotrexate when BHCG levels were less than 5,000 ml, but dropped to about 80% when levels were 5 to 10,000 ml. Success was less than 70% with an initial BHCG level of greater than 15,000 ml. Patients who are Rh negative should receive Rh immunoglobulin. Failure of medical treatment is defined when BHCG levels increase, plateau, or fail to decrease adequately by 15% from days 4 to 7 post-injection. Investigational medical treatments. The use of oral methotrexate is under investigation. Although preliminary reports show promising results, efficacy remains to be established. Although methotrexate has remained the most effective and popular drug used in medical therapy for an ectopic pregnancy, other protocols have been used, such as potassium chloride, hyperosmolar glucose, mifepristone, Ru4A6, and prostaglandins, and these agents have been administered orally, systemically, and locally into the ectopic pregnancy directly. These therapies remain experimental at present because the efficacy of such treatments, as well as their advantage over standard methotrexate protocol, has not been established. Thank you for joining us in this educational journey on understanding the use of methotrexate in treatment of ectopic pregnancy. Stay informed and take proactive steps to safeguard your health.